Thanks, Amanda, and thank you, Dr. O'Callaghan. That was awesome, and learn a lot from that, actually. One, that you've got a great sense of humour and you should be speaking more at POTS conferences, I think. Okay, let's just see if this is going to work from here. Beautiful. So as was said, I'm actually a nurse and I worked in emergency, was my real main area back in Monash in Melbourne, which is where I lived for 10 years with my family. I had POTS at that time. I got POTS when I was 24 from a virus, I assume, or at least that's what happened at the time. And our family does have the connective tissue involvement, which I didn't really find the connection to until I came across Dr. O'Callaghan with one of my daughters. I really didn't want to get involved in this space too much. I knew from the back corridors of hospitals what people thought about POTS patients, and I didn't fancy that I would put myself in that position. And it wasn't actually until I had a flare of my POTS about 3 years ago that I ended up probably the sickest I've ever been, and at that same time happened across Dr. Lau, who some of you may know, who has a habit of challenging people publicly to take up PhDs, so run when you leave the auditorium today. But Dennis has been great and instrumental in me coming forward with marrying together my whole history personally, but also my clinical history. We were fortunate in that just when I took on my PhD, we weren't fortunate really, but the world went into the SARS-CoV epidemic, and we started to see patients coming through with long COVID, and I just happened literally in the first month to decide to apply for a funding grant from overseas, because of course there's none in Australia really that's accessible to us. And we got a funding grant, literally we applied for it and 10 days later I was funded to undertake a study in long COVID before it was even called long COVID really. So this talk is really me with three hats on. One is a researcher, but it's not going to be really too research focused. One is somebody speaking from the foundation and really as a patient of this, and one is a nurse educator, which is what I do most of the time actually, more than anything. So basically the usual disclaimer, especially since I'm the only non-medical doctor here, and I'm very aware of that in terms of speaking in front of you today. So this is more about our experience than anything. And these are my two supervisors. You're standing in this building here at SAMRI who supports us. Dennis is my primary supervisor, and Seeley also, who we all work together clinically. And Standing Up to POTS is the great foundation in America who supported our work, and we're very thankful to them for that. So I just want to start with a little bit of a talk about the terminology, because there's a lot of confusion out there, as there always is with what is considered a new condition. So we have a lot of terms for long COVID. We have the post-COVID-19 syndrome, which is used more by the Europeans. We also use this post-acute sequela of SARS-CoV-2, which is used a lot by the Americans and is becoming more a term that we use, PASC, and I like it because it's a lot shorter than saying COVID, long COVID at least. And other people refer to it as post-COVID-19 condition. That's what the World Health Organization uses. And some people refer to it as long haulers in the first kind of months of discovering what everybody perceived to be a new condition. In terms of definitions, I really like the National Institute of Health and Care Excellence. We lived in the UK for a long time, and I can't say I really enjoyed some of the medical care there, but they're very good at putting together structures. That's what the Brits do the best, I think, that and queuing. And so this long COVID is a term that they have broken down into two aspects. One is the ongoing symptomatic COVID-19, and they perceive that to be in the first 4 to 12 weeks. And then when we talk about post-COVID syndrome, we're talking about greater than 12 weeks. And in post-COVID syndrome, we're talking about people who have signs and symptoms that develop during or after the infection, consistent with COVID-19. So they haven't put a requirement on that there be confirmed COVID, and that's important for those who suffered this condition early on before we had the advent of PCRs that could detect it. and it has to continue for more than 12 weeks, and that it's not explained by other alternative diagnosis. And that's really important. We get a little bit of kickback from people saying, oh yeah, but they have all these other things. Well, if they have other conditions that we can determine, then we're not going to call it PASC or long COVID. So if they have parenchymal damage, myocarditis, CNS disturbance from COVID, that's clearly going to be the driver of a lot of their symptoms. So we're talking about people with no other explainable etiology apart from a viral infection and then these unexplained symptoms. The World Health Organization were quite helpful in coming out and really confirming this, and so they've put together a clinical case definition that's helpful for us. So again, saying that this is a probable SARS-CoV infection within 3 months of onset of acute infection. So I think that's really important for the autonomic space, because we know that autonomic disturbances can sometimes take a while to manifest in patients. They're very subtle, some of the changes, and sometimes we don't really see a great change until some months down the track in some people. The symptoms, they say, should last for at least 2 months. That's interesting in the context of the international 6-month criteria for POTS. We really have brought that back a bit to the 3 months more recently. And again, it shouldn't be easily explained by other etiologies. So what does autonomic dysfunction have to do with PASC? I think after today's lectures, you can probably hazard a guess at that. When you work in the space, you think autonomic function has to do with absolutely everything in life, and so it should, because it controls all our unconscious functions that keep us comfortable, essentially. But what does it have to do in terms of literature? So we did see a lot of case studies coming out about this. In fact, we're doing a scoping review at the moment, and there's something like over 20 kind of case series and independent case studies that started to come out as soon as long COVID became a thing. And then we saw some of the international experts. So Satish Raj there, a lot of you will know, he's now in Calgary. He leads a lot of the cardiology kind of research and more narrative around POTS. And then also Dr. Schofield, who's down in Colorado, she does a lot of the immunological kind of aspects of POTS. There was lots of cross-sectional surveys, which POTS research is really good at, because what else do you do if you don't have any funding? You do a lot of cross-sectional studies, and so using the COMPASS survey, there was a lot of people coming out with these quite large studies showing a large percentage of these long COVID patients, so past the 3-month stage, had quite high levels of COMPASS dysfunction, and that suggested broad-spread autonomic dysfunction. Then we had actually the first real prospective evaluation, or at least the first one anyone noticed, because it was published in JACC, and so then we all had a look at that. That just looked at 24 patients that were tested essentially for their autonomic function on standing tests, tilt tables, and that came out, of course, and said that the majority of those did have some form of dysautonomia, and POTS was in there with that. Dr. Blair Grubb, who's really, well, he would probably hate me to say, but one of the grandfathers of POTS research, he's very passionate about this, a cardiologist. He was the first to really come out and say, hey, we've seen this before, this isn't new, it's just a new twist on an old problem. There were others who pointed to the fact that there was an acute affection presentation of autonomic dysfunction, as well as that secondary autonomic dysfunction in the chronic state. And so the research goes on and on and on and on, and there was, hundreds of them. And so this wasn't really surprising to anybody who's been in this space before, and there are some people in this room that I know have worked for probably decades in this area and were probably equally frustrated to hear the narrative of, wow, look at this new condition that we're coming across. It may have a slightly different presentation, but predominantly we've seen this before. And so this was quoted today. I can't remember who said this, but there it is. Those who fail to learn from history are doomed to repeat it. And it's interesting, the older you get, the more you realise how quickly things fade from our memory. So we're just going to look at a few things that aren't that long ago. Some of you will be familiar and some may never have seen this. But one of the first real epidemics of note in terms of the world understanding about it, and that was probably because that's when we're starting to really publish literature, was the Royal Free Hospital epidemic that had a paper published about it then and successively. In that epidemic, over 300 staff and associates of the Royal Free in England, London, fell ill with a mystery illness. Over 200 of them ended up hospitalised at that time, and their symptoms were quite varied, but ones that we see quite a bit of with most infectious outbreaks, so headache, fever, malaise, myalgia, nausea, dizziness. Initially, there was actually the infectious diseases doctor there, Dr. Ramsay, and so he undertook quite a lot of, both then and for the rest of his career, actually, he did a lot of research around what happened at the Royal Free and in subsequent epidemic outbreaks. So none of the bloods showed anything. That will be familiar to those with long COVID and who work in that space. There was a little bit of leukopenia that was noted in some normal ESRs. Today it would be normal ESRs and CRPs. Iron studies were normal. There were abnormal EEGs. They didn't do them on many, but those that they did do them on, half of them were abnormal, which was of some interest. And there was mild pyrexia with really severe disproportionate myalgia, so that they described people laying and screaming and crying in pain. And some of these were the senior doctors in the hospital at the time. Unfortunately, and this sets the scene really for the following decades, that there was a psychosomatic attribution to this that came out 15 years after the epidemic. So 15 years later, there was a psychiatrist, or two psychiatrists actually, a junior and a senior, who came out and wrote a paper. They did a re-evaluation of the case notes, and from that reanalysis of the case notes of the patients with the Royal Free disease, it is concluded there is little evidence of an organic disease affecting the central nervous system, and that the epidemic hysteria is a much more likely explanation. So McEvity's conclusions were disturbing, partly because they were based on the fact that there was a predominance of women in that cohort, so that was the reason why hysteria was the most likely cause. But also that there was disproportionate myalgia to pyrexia, so that was really more an epidemic of lack of understanding of your own ignorance, in my opinion, but anyway. But the really disturbing thing was he never actually talked to any patients from the Royal Free, nor did he really make any real investigation in any sense of the term. He visited there for 2 hours to the records department, and the PhD was published off the back of that. The difficulty with this was that it was published in the BMJ, and that perpetuated really a story of psychiatric component to myalgic encephalitis, which is what that disease became known as from the Royal Free. Dr. Ramsay spent the rest of his career trying to counter that, and he, in 1978, tried to counter those articles by saying, actually, we saw a lot of these objective symptoms at the time, and this often took the form of orthostatic tachycardia, which does not occur in cases of hysteria, chilliness of the extremities with increased sensitivity to cold, circulatory impairment and hypothermia. If anybody's got POTS, you'll recognise all of those symptoms. There was also, this paper was published in 2021, which is interesting, right during the pandemic. I don't know if that's what instigated this, but this came out from the Royal Free by a group of doctors who were there at the time, and a couple of nurses as well. Some of them had experienced the actual disease themselves. They went back and did a reanalysis of those papers. There certainly was evidence of ptosis, of the eye drooping, of enlarged lymph nodes, of hemiparesis, of extreme myalgia, nausea and vomiting, abnormal EEGs, and some evidence of enterovirus in some patients at the time. In terms of recovery of those patients, it's not really clear what happened, but we do know that Dr. Ramsey detailed that he put them into 3 categories. So there were those that completely recovered, and amongst those were ones who completely recovered, but not until 10 years later could they return to work. So, you know, that's a pretty poor term of recovery, but they did recover. Some did recover but were prone to these relapsing episodes, including this extreme physical fatigue, and then there were ones who actually never recovered in terms of returning to work, although it's not clear that any of them had shortened lifespans. That wasn't really followed, unfortunately. So this is Dr. Ramsey. The advice that is often given to snap out of it is totally misplaced and wrong. There were multiple other epidemics. I won't take so much time with them, but this is another one that made a lot of kind of noise in the US, where there was a town on the Lake Tahoe where there was an outbreak, and there were, you know, around 300 residents who had these same kind of flu-like symptoms with brain fog, depression, headaches, arthralgia, paresthesia, loss of appetite. This quote really, I think, for some of the long COVID patients, particularly those who were in Europe at the outbreak of COVID over there, marathon runners overnight could not climb flights of stairs, and people who set out in the morning to work had to be carried home. And those who could still drive got lost trying to find their way home, and a math teacher could not do addition while an English teacher could not conjugate a sentence. And that was by a man who experienced the outbreak and has gone on to do a lot of work in trying to figure out what those people suffered himself. Unfortunately, again, this was associated and attributed to psychosomatic disorders. The CDC in particular were slightly unhelpful in the way that they reported this, and they didn't really do a great, thorough investigation. Dr. Daniel Patterson, who treated most of those patients in that town, points out, you know, until the 1950s, we thought MS was also a psychosomatic disease. I'd like to think that we've learnt a bit about that over the years, but a lot of that is lost, I think, to the medical memory, really. And so just to remind you, for the sake of time, we've just had outbreak upon outbreak upon outbreak of diseases. These are a handful. I could have put another 5 slides together. You can see the terminologies used there, and we've got a lot of abortive poliomyelitis, a lot of these without identifying actual enteroviruses, and not with the central nervous system disorders, but with autonomic dysfunction and some slight central nervous system signs coming in there. So this really is a disease of 1,000 names and no real name. And it's very difficult to name a foundation after a disease when you don't know what that disease really is. And we had trouble with that. And as we've all said today, we don't like the name POTS. I hate it. And I tell most of my patients, you know, POTS really isn't that helpful for us in terms of describing your life. It describes a symptom. It's a bit like calling a disease, say, hematuria, and thinking that that means anything to the patient, but it's what we've got, and it's a name that's in the ICD-11, so we need a name to be able to quantify this. So what's our experience with PASC? We had the unfortunate or very fortunate situation where we're living in one of the best states in terms of controlling COVID, and I just managed to get a grant for studying long COVID, so that really threw a spanner in the works, and for a long time we found it difficult to recruit patients, and I wasn't allowed to travel anywhere. But in the end, we managed to get a prospective comparative study up between a POTS, PASC and control cohort. This study was looking at cognitive function in those patients, symptom and health-related quality of life surveys, blood and urine, autonomic testing, which we used the standing test with beat-to-beat monitoring using the Nova Phenopress, Valsalva, deep breathing, Pseudoscan was in there. Now, I'm going to show you kind of 2 lots of data just to give you a bit more of an experience of what we see in our clinic. I'll show you first just a PASC kind of cohort. So these 54 in here, these are just the ones that have enrolled in the study and had that testing, but we see quite a few others, and of course this doesn't include our adolescent cohort, and yes, adolescents definitely get long COVID. So the ones that I'm going to talk about today got their infection between March 2020 and July 2022. 69% of ours were diagnosed on PCR, 22 on RAT. We included those that did not have PCR or RATs because we had patients who had gotten COVID in Europe and it had returned, and we just felt it was clear that they'd had it, so we allowed for physician confirmation of their infection, likely infection. Our mean age is 38, around about there, and as with POTS, you know, it's 80% female dominant and 90% Caucasian dominant. That's another research topic for everybody to look at, whether that's just referral bias, we don't know. 69% of our population, these 54, were vaccinated with at least 2 doses prior to the infection. The other ones didn't have the opportunity to be vaccinated before infection. So 33% of our population have presented to ED, only 1 was admitted, and I put that in there because we often get the usual old story of, oh, this is deconditioning for, you know, 9 months past their infection, but it's not. Onset of orthostatic intolerance was about a mean of 12 days post their acute infection, with a range of 1 to 68 days, and that's just to show you the length of delay in some people in coming out with orthostatic intolerance symptoms. At the time of testing, so when they undertook their testing with us, it was a mean of 270 days of long COVID. So, you know, it's a relatively chronic time by then. It certainly shouldn't be that initial deconditioning time. In terms of just looking at the impact of them, amongst that cohort, there was about 15 days of work missed as the average in the last month. This table's a little rudimentary, but I think it's helpful in looking at where the progression goes here. So this is the acute infection symptoms on the left there in that chart. So 83% had headache, which you would expect, and we go right down to all those symptoms. And then we asked them at the time that they had their study with us, what were their symptoms at that time? And you can see the ones I've highlighted in the red are all symptoms really of autonomic dysfunction that have progressed in that 3 months or until they came to see us. For some of them it was a year. So in some of those, particularly the palpitations and the tachycardia and the dizziness, have almost doubled or more than doubled in some of them. So you can actually see the autonomic dysfunction here, all the things that we see in autonomic dysfunction. So the shortness of breath, palpitations, tachycardia, dizziness, gut dysfunction. Polyuria, which is the poor cousin of every other symptom, is one that is really quite striking in some people, particularly in the acute phase, but then it becomes a chronic thing for them. And the brain fog, the all familiar brain fog, which is a symptom of a million diseases. So when we did do the standing test, out of those, I've just thrown together some of our PASC and POTS plus the controls in there just to give you a comparator. So obviously all the POTS have POTS, but you can see there in the orange that the PASC cohort, 74% meet the criteria, international criteria for POTS, so that's excluding the orthostatic hypotension, excluding other markers of diseases that might be causing this. And so still you've got quite a high percentage. And then if you look at the symptomatic heart rate to 25 to 29, part of the reason I hate POTS terminated, because are we really going to say somebody with a heart rate, delta heart rate of 29 doesn't have POTS because it's 1 beat per minute off what it needs to be? That's the criteria, but we actually had about 4 people came in on the 29 beats per minute on the standing test. So they're symptomatic. Really, they have this broad spectrum of autonomic dysfunction. It's just at that moment in time it wasn't as obvious as the others. There were a few that don't have any positive standing tests there, but they still are very symptomatic, and that's good to show people there is definitely a disease process that is difficult to quantify in some of the cohort. Right, I'll flick on from this a little bit, but that's just the COMPASS score. So if you're not familiar with the COMPASS, it looks at 6 domains of autonomic dysfunction. The primary ones that we really look at are the compass total, which is a good indicator of autonomic dysfunction. If you work in general practice and you want to use a tool, that's one that we would probably recommend. It's out of 100. Anything over 20 is a good sign of kind of moderate autonomic dysfunction. You can see there that the POTS cohort has obviously quite a high autonomic dysfunction, mean being 53, but the PAS comes in pretty close with a 41. Same with the orthostatic. Intolerance is obviously quite high in those two cohorts compared to controls. This is hypermobility. So going back to Dr. Burling's talk, it's remarkable how much hypermobility crosses over in our cohorts. So POTS over there, 51% of our cohort. This is using the Hakim tool. So we didn't assess everybody on the 2017 class scale because we didn't have the time. But also we just did a cross-sectional, here's the 5-point questionnaire. So it's pretty sensitive, that tool, we find. And if it falls anywhere, it falls that are underdiagnosed. So some people, particularly men, don't think about whether they could do the splits when they were 5. So they tend to not self-report hypermobility. So 51% of POTS were hypermobile and 39% of the PASC were also hypermobile, whereas only 10% of our controls were hypermobile. There's just some of the pictures. There's our standing test, the delta heart rate. You can see again the PASC is just slightly under the POTS patients. That's probably typical because obviously we've got some people in the PASC group that don't meet the criteria for POTS, but all the POTS people in the PASC are quite similar to our POTS, if that made sense to you at this time of the afternoon. There's the compass scores, so orthostatic intolerance, vasomotor, secretory motor, GIT, bladder and pupillary motor is what we look at, and there's significant differences everywhere. I'll just make a note on the pupillary motor. We did some other testing around this, and it came out as highly associated with reduced quality of life, which I found really bizarre when I was looking at that research. Because we never talk about it, and we don't ever ask our patients really. They often self-report the sensitivity light and the blurred vision. Why it's associated with reduced quality of life, I don't know, but all I can gather is that maybe it's a sign of worsening autonomic dysfunction, and that might be a marker that we should look at a bit more. So we use the EQ5D5L, which is a rating of quality of life. The patients look at self-report their kind of disability across 5 domains, and then we have a VAS score where they self-report their health on that day. And then we can apply a database, an algorithm using a preference-based value system, which we used a UK one to come out with a utility score, 0 being shocking health, basically death, and then 1 being the top. So if we look at this, we can see that the normative data there, they've got a 0.94 in terms of quality of life, which is, these are age and gender matched. And that's comparative to our PASC population of 0.61 and then the POTS at 0.64. The PASC population also self-report worse health, but they're more acute than our POTS patients who had this condition for quite a long time. I think the mean of duration of the POTS was about 7 years that they had it. This is just to show you generally what POTS can do. It's not well, covered, the quality of life. Everybody knows it's not fantastic, those people that work in the area. But this is comparative to a meta-analysis done using the EQ tool, the 5D. And so these authors, this is our normative population, 0.92, so really good health for the age and gender matched population. And then we go down, we've got these HIV, diabetes, COPD, we go down the track and then we get down the bottom, POTS, this is 202 of our patients, 0.59 was their mean EQ score, and then sitting below it was MS. And that's a pretty damning figure to show in a disease that doesn't even have an ICD code, and most doctors I know haven't heard of it until you tell them about it. One thing I want to mention is fatigue, and it is the all-encompassing problem in this disease state, and it's really difficult to get a handle on it. You can see in this graph that we've got some patients with PASC who don't report fatigue actually. This is using the fatigue severity score, and in the mean up here we've got a mean, I can't actually even read that, but somebody else might be able to, but it's about 50 something. So the fatigue score is out of 63. You can see most of the population sit up here. There's a few that don't have fatigue, but they have other symptoms going on. And we can compare that to the fatigue. This is over 400 of our patients, POTS patients. And again, you can see you get this slight group of people down here that have zero fatigue. You know, they've got heart rates of 160 but no fatigue. But the majority of our patients do sit up here in this extraordinary, you know, state of fatigue that is just incomparable to every other one of their symptoms. And a lot of them, 70% of them, say that exercise worsens their fatigue, and that's an area for the exercise physiologist to be involved in. I just want to make one last real note as I head towards the end here, and that is how much the vasomotor response, and Chris really, I think brilliantly detailed that this disease state is really about the vasomotor response and what that does in terms of the patient's symptoms. And we can relate almost everything back to this blood pooling issue, so poor preload and then the sympathetic response to that. And it's really important for the GPs, I think, who are at the coalface of seeing people with these complex conditions to be looking out for these signs of the labile blood pressures, the Raynaud type phenomenon, which is quite new in a lot of our PASC population. Livedo reticulatus, we see quite a bit that lacing pattern, the hyper or hypohidrosis, and the dependent acrocyanosis, which you see here in this patient. And this is just talking about our brain fog. Just so I haven't got any evidence on this here today to show you, but we've got people in the room that have written papers on this and shown the cognitive effects in ME/CFS, which is a merged condition with POTS. A lot of the ME/CFS patients have autonomic dysfunction and vice versa. We did a comparative in our study. We looked at the CANTAB, which is the Cambridge Neuropsychometric Studies. PASC were head against POTS in terms of they had really reduced sustained attention, delayed psychomotor response, reduced ability to multitask, and that's despite them being on the par of education with both POTS and control. POTS were also behind, but not quite as substantial. In terms of looking after these people, I love this quote: "One doesn't have to operate with great malice to do great harm. The absence of empathy and understanding are sufficient." And a lot of our PASC population have faced a lot of great harm in terms of comments and dismissiveness from the medical society, and we've got to be a lot more careful about that. We're actually loading harm onto patients that have great harm. We've had, I could have put up 1,000 quotes, there's just some for you to read as we go on, but we have people who have seen multitudes of specialists with no answers. We've been told repeatedly by them that they're told that it wouldn't matter if they got a diagnosis of POTS, it won't help them, and that's not true, because if you give people understanding about their condition, they have the mechanisms then to enable themselves to help themselves. But giving them no hope is really, it's causing harm, and we need to really stop that. I just want to make a last note that we do have paediatric patients who get this. It's more subtle in some, it's very dramatic in others. We see many in hospital with nasojejunal feeding tubes and on watch by psych teams because they think that they've got eating disorders, but these are sudden onset after COVID. But in most of the population, it's quite subtle, and you should be looking out for increasing absenteeism, reduced academic, social withdrawal, reduced performance. We get quite a lot of athletes who that's how it's picked up. They're dropping out of their athletic programs, and our EPs are picking it up because they're going, why aren't these kids able to participate? And they send them up to see us. look out for increased headaches and loss of appetite in these kids. So I had a doctor here say to me one time, oh yeah, but some of those POTS patients didn't actually have POTS. And again, that's a bit like saying those patients didn't have hematuria. I mean, POTS is just a description of symptom, and I hope one day we won't have a POTS foundation because we'll find out what the underlying causes of these are. It is the final common pathway for a multitude of diseases, and that's what makes it so hard to actually investigate and research, but we hope that we're going some way towards that today with this conference.